So the question is, if you treat brain pathology, where should you target? In the sense, can you put an electrode anywhere in the brain? Use TMS or TDCS everywhere? Well, to make it relatively simple, if we conceive of the fact that there is a symptom generating network, and that symptoms or diseases or brain disorders are an emergent property of a network phenomenon, then of course, if you stimulate out of the network, you won't modify the symptom generating network. Whereas if you stimulate the network anywhere at any spot within the network, you might have a beneficial effect. This being said, what would be a good target, considering the fact that most axis 1 disorders like schizophrenia, depression, OCD, addiction, bipolar disorder, anxiety are related to the salience network. Of course, targeting the salience network at one of its hubs seems to be logical. And if you do not respond, it might be because you're a little bit too posterior or a little bit too anterior of the target that is part of the network that generates the symptom. Now, from a practical point of view, if we want to change behavior or symptoms or disorders by brain modulation, we should understand well what we're doing. And recently a very beautiful, elegant theory has been developed of how behavior, in its broadest sense, is controlled by brain networks. So, from a practical point of view, the pre-general anterior cingulate is involved in encoding the reliability of the current behavioral strategy. So your ventromedial prefrontal cortex extending in the pre-general anterior cingulate tells you that what you're currently doing is good, is reliable. Now, the reliability of alternative behavioral strategies is encoded in the dorsolateral prefrontal cortex. So if your brain says, this is what we're currently doing, then all the alternatives are computed in parallel in the dorsolateral prefrontal cortex. Now, when the reliability of what you're currently doing decreases, then your brain will switch to another alternative, and the switching is encoded in the dorsolateral prefrontal cortex, rostral to dorsal, extending into the SMA. So basically, in that very moment, your brain will switch its activity, and what was currently done will then become computed in the lateral prefrontal cortex, and one alternative strategy computed in the lateral prefrontal cortex will become the current strategy. And this switching occurs by the dorsal ACC. Now, the rejection of the current strategy is encoded by the ventrolateral prefrontal cortex, which makes sense because there is some information that overrides, that breaks the current circuit. And the confirmation of the new behavioral strategy as becoming the actor is encoded by the nucleus accumbens or the ventral striatum. So basically, your nucleus accumbens or your reward system just tells, yes, I confirm this new strategy should be what we're currently going to proceed with. Now, if you apply this to pain, for example, then the dorsal ACC switches, over here, switches to the painful state via the habenula, and the accumbens confirms the painful state as a new reference, as the most reliable way to be in right now. And the pre-general anterior cingulate confirms the painful state as reliable, and the connectivity between the accumbens and the pre-general maintains a painful state. And this has been shown indeed that both structural and functional connections between the nucleus accumbens and the pre-general anterior cingulate are critical factors in progressing from acute pain to chronic pain. That being said, so in chronic pain, basically the painful state has become the new reference, the new actor. Now you could say exactly the same thing for tinnitus. In tinnitus, the dorsal anterior cingulate switches the tinnitus state to the tinnitus state, and Ackermann's confirms the tinnitus state as a new reference. The pregeneral anterior cingulate confirms the tinnitus state is reliable, and the functional connectivity between the Ackermann's and the pregeneral anterior cingulate maintains the tinnitus state to become chronic. Addiction, same story. OCD, the same story. So basically, it's a other way of telling that dorsal anterior cingulate give me more, pregeneral I have enough, and that the balance between the two is controlled by the Ackermann's. So it's basically, and that this balance is maintained by connections between the Ackermann's and the pregeneral anterior cingulate cortex. So it's a very elegant theory that fits with what we previously saw. So what about pain? Now in pain, there have been implants in the anterior cingulate as performed by Tipo Aziz's group in Oxford, and they were treating with a traditional 130 Hertz stimulation at high voltages with normal pulse widths in tonic matter. And they were treating the affective component of the pain. And so there was 24 implants. And what you see is that the numeric rating scale goes down during 6 months, and then after 6 months it goes up, and after 24 months it's exactly the same as before. The McGill Pain Questionnaire goes down, and then after 6 months it starts going up. The SF35 improves and then goes down again, and the Euro call actually goes down and then back up. So basically the problem is the beneficial results are not maintained beyond 6 months. Now in tinnitus, we know that there is, in the pain, that you've got the painfulness perception is encoded by the lateral pathway. The affective component or the suffering is encoded by the medial pathway, and actually in tinnitus you've got the same pathways. So you've got basically the auditory pathway, the lateral pathway, and you've got the medial pathway, which encodes the affective motivational component, basically the suffering associated with the tinnitus, and the tinnitus loudness is encoded predominantly by the lateral, but actually also by the medial pathway. So tinnitus distress or tinnitus suffering, if you analyze it by a simple Fourier analysis, you see that you have high beta activity in the dorsal part of the anterior cingulate. And any planar component analysis localizes it a little bit more anterior, actually, and then region of interest analysis with Fourier shows that it is associated with an increase in delta and gamma on the right side and a decrease in delta and gamma on the left side. So tinnitus distress, in summary, is encoded by predominantly the medial pathway. Tinnitus loudness, however, is also encoded by the medial pathway, but also by the lateral pathway. And therefore, it is important to realize that for tinnitus loudness, when you modify the suffering, probably the loudness should also improve. So you can target the dorsal part of the anterior cingulate by using this double coil TMS. And what you see in single sessions is that in comparison to sham, actually the tinnitus increases with low frequencies and decreases with high frequency. Same for distress. Now, and that repeated sessions are better for tinnitus intensity. If you do multiple sessions, that the benefit is way better than if you do only a single session. So repeated sessions do make sense. So here's some two patients with basically exactly the same kind of tinnitus. So you have patient 1, 64-year-old male, bilateral noise-like tinnitus since 39 years. So very long-standing, extremely loudly perceived because the VAS loudness and the VAS distress are both maximum. So the patient is severely suffering from an extremely loudly perceived tinnitus. It is perceived at 4,000 hertz and 10 decibel above hearing level. Now, it's a grade 4 tinnitus, which means it's psychologically decompensated tinnitus, which you could already figure out from the loudness and the distress rates, and associated with the depression. TMS is performed, and there is a fairly good reduction of the global tinnitus scores. Second patient is same age but female, unilateral noise-like tinnitus since a shorter time but still long-lasting, same loudness and same distress, same tinnitus frequency, and also grade 4. TMS has less than 30% reduction, which is meaning, well, it might work, it might not work. So the patients are implanted with electrodes in the anterior cingulate cortex, here and here. And this is in live, where the brain is pulled slightly apart so that the electrode can be inserted in between the two hemispheres on the anterior cingulate. Preoperatively, the grade 4 tinnitus after tonic stimulation goes to grade 2, so it's beneficial. The loudness decreases on the left and the right. The distress decreases, the percentage of the time is halved, anxiety and depression were not recorded. And then the patient was clearly better, but it still switched to burst mode, where basically the loudness is further improved and the depression is gone as well. And there's basically the 6 Hz burst mode is superior to 2, 4, 8, 10, 20, 40 Hz burst mode, and superior to 6 Hz tonic mode. Second patient, which is basically clinically exactly the same as the first, has no benefit whatsoever. Everything we tried really basically failed. So we want to understand what is the difference. Why does one respond and why does the other one not respond? Well, the reason is the electrode is on the anterior cingulate cortex, which is on the where we put the seat for the functional connectivity measurements. And what you see is that the first patient has a hyperconnectivity associated with her distress and her tinnitus loudness, whereas the second patient is non-responder, has hypoconnectivity in comparison to healthy controls. So the hypothesis is basically that here, when we target that area, the connectivity is reduced by inserting this electrode, whereas here, because the connectivity is already decreased, we can't seem to normalize the decreased connectivity, which is interesting because that means that both hyper and hypoconnectivity can result in the same tinnitus. Now, is this a unique finding, or do we have other arguments? Yes, a couple of years ago we implanted failures to auditory cortex stimulation for tinnitus. So we implanted the electrodes on the auditory cortex, and then we compared people who responded to the implant to people who did not respond to the implant. When we subtracted their brain activity on EEG, what we found was actually that the difference was in the parahippocampal gyrus and was not in the auditory cortex, which is what we expected. So then there was a problem in that patients who responded had increased activity in the parahippocampus in comparison to the people who did not respond, but the electrode was not in the parahippocampus, the electrode was on the auditory cortex. So what we then did is we looked at functional connectivity between the place of the electrode and the parahippocampal area, and responders also had increased functional connectivity, which means that we could get to the problem by using connectivity of an area that is also that makes a link to the area that we are truly targeting. So what about addiction? Addiction criteria have changed recently. So now DSM-5, DSM stands for the Diagnostic and Statistical Manual for Mental Disorders. It does not mention addiction anymore, but substance use disorder. Just give the child a name. There is now 11 criteria. So when you take in a substance in larger amounts or for longer than you meant to, is one of the criteria. If you want to cut down or stop using the substance but are not managing to, if you're spending a lot of time using or recovering from the use of the substance, if you have craving or urges to use the substance, if you're not managing what you should do at work, home, school, or because of the substance that you use, if you continue to use even when it causes problems in relationships, if you give up important social, occupational, or recreational activities because of the substance, if you use the substance again and again, even when it puts you in danger, if you continue to use even when you knew you had a physical or psychological problem that could have been caused or made worse by the substance, if you need more and more of the substance in order to get what you want, which is of course the development of tolerance and development of withdrawal symptoms, which can be relieved by taking more of the substance. So depending on how many of those criteria you have, substance use disorder is considered mild, moderate, or severe. So if you have two of those criteria, it's a mild substance use disorder. If you have 4, it's moderate, and if you have 6 out of 11, then it's considered a severe substance disorder. Now, why would people drink in the first place if we talk about alcohol addiction? One is to feel good, which is called reward drinking, and the other is not to feel bad, which is called relief drinking. Now, you might say, well, this is the same, but it's fundamentally different, because this is what students typically do. They go out, they have a couple of drinks, and they feel good. Now, these are people who feel bad. They're depressed, they're anxious, they have personality disorders, they're depressed, and when they drink, they feel less bad. Now, therefore, alcohol dependence is critically related to relief drinking, and that's why alcohol dependence or substance use disorder is associated with mood disorders, anxiety disorders, or personality disorders. And of course, those are especially at risk for addiction. Now, the biggest problem of addiction or substance use disorder is relapse. And 85% of the patients with alcohol dependence relapse within 2 years. And the 3 main reasons for relapse is craving, cues, like if you walk into a grocery store and you see beer or wine, and or stress. Now, the beauty of this is that the circuitry that is involved in craving and stress are very close or even overlapping, and so you could treat the craving and the stress in order to prevent relapse. Alcohol craving is in the rostral part of your singlet. Food craving is just adjacent to it, and this is a more general addiction network. So addiction can be seen similarly to chronic pain and to tinnitus as the result of a paradoxical savings attached to the substance of abuse and an imbalance between input and suppressing activity. So if you have more craving and less suppression, then basically you might be addicted. So I'll start with a case report where you see a 38-year-old person presenting in the clinic for alcohol addiction. He started drinking at 17 because of agoraphobia with panic attacks. So he was scared when he had to start, when he had to go outside basically, which was associated with panic attacks, and these panic attacks improved with alcohol. So he had episodes of binge drinking until he lost consciousness, and he woke up at night only to restart drinking, recovering from his coma basically. So he tried everything. He tried Alcoholics Anonymous, psychologists and psychiatrists, mindfulness meditation, anti-abuse implants, and several psychiatric inpatient admissions. So basically, he was only 30 years old, but he was lost for himself and for society. So when we presented alcoholic images versus non-alcoholic images, we saw a hot spot close to the dorsal part of the anterior cingulate. And if we compared his EEG to the EEGs of healthy controls, we saw an increase a little bit more anterior in the rostral part of the anterior cingulate, extending into the dorsomedial prefrontal cortex. So we used TMS with a double cone coil, and it reduced his craving from 8 to 2, but he had a relapse after 3 weeks. And so we proceeded with an implant on the anterior cingulate cortex, and that has reduced his craving from 8 to 2 after which was maintained till 18 months, and now it is maintained for almost 7 years. So the EEG shows overactivity in the dorsal part of in the rostral part of the anterior cingulate, and after treatment you see that we might actually be over-treating it a little bit because it has been suppressed even more than in healthy controls. So subsequently we've implanted more patients, 8 more patients with alcohol addiction. What you see here is their EEG before the implant, and you see that in comparison to healthy controls, they have overactivity in the rostral to dorsal part of the anterior cingulate cortex, and that when we treat them, on average, their craving goes down from 7 to about 2 for on average, and there is 2 failures in the study, and on average they drink 22 standard drinks less every day. And this improvement in craving is associated with a reduction of the overactivity, and this is a whole brain analysis of the overactivity in the dorsal part of the anterior cingulate. So it seems to be beneficial in some patients with tinnitus, with pain, possibly with pain, but pain doesn't last if you don't treat it with burst stimulation. With burst stimulation, it seems to be long lasting. So what about OCD? Now, OCD is obsessive compulsive disorder. It has a lifetime prevalence of 2.3%. It has severe functional impairment, basically because of anxiety and distress, and obsessions and compulsions. So obsessions are persistent and repetitive, unwanted, intrusive thoughts. So they're thought problems, and compulsions are ritualized behavior, the hand washing that we know, putting all the forks and knives extremely careful in the drawer, etc. And the phenomenology comes in 4 dimensions. One is symmetry aspiration, where everything has to be symmetric. One are taboo thoughts, which could be aggressive, religious, sexual, or somatic obsessions, and check-in compulsions, whether they have locked the door, whether they have done something. Contamination, cleaning of or washing their hands repetitively, and then hoarding, obsessions and compulsions. So basically, phenomenology, 4 dimensions: symmetry, aspirations, taboo thoughts, contamination, and hoarding. And unfortunately, 40 to 60% are intractable to cognitive behavioral therapy, multiple medications, and therefore singulotomies and capsulotomies are being performed. Now, the circuitry of obsessive compulsive disorder involves the dorsal anterior cingulate, the rostral to dorsal anterior cingulate, the orbitofrontal cortex, dorsolateral prefrontal cortex, caudate, and thalamus. And of course, the question is, can you treat it? Yes, and people are being treated by anterior limb of the internal capsula lesions and implants. And the question is, could we treat the dorsal part of the rostral to dorsal part of the anterior cingulate as well? So here we present a 47-year-old woman with alcohol addiction and OCD as a relief drinker. Her Y-box drinking scale is 25, basically more than 7, discriminates between social and alcohol dependent drinkers, so she's clearly alcohol dependent. She has severe OCD, and the OCD is predominantly related to obsessions, more so than compulsions. She spent between 3 and 8 hours per day that she loses basically on obsessive thoughts, with basically 1 free hour per day to function normally. She had some residential admissions, outpatient treatments, lots of medications, and when we use TMS or double cone call, she improves both for alcohol and OCD. And she, after TMS, her OCD basically halves from 29 on the Y-box to 14. So she's implanted with an electrode, and as you can see on the raw scores and the percentage improvement, what you see is the Y-box drinking scale goes down, the alcohol craving goes down, the alcohol urge goes down, and the depression also goes down. What is interesting is when we this is a ratio that we compute for the dorsal to pre-general anterior cingulate cortex activity, and when she's clinically good, her alpha activity is up in the ratio between those two areas, and when we switch her to 40 and 20 hertz, actually the alpha goes down, and she has a clinical deterioration, so that ultimately she could not drive to the hospital to get reprogrammed. Once we reprogrammed, the alpha activity in the ratio went up, and she clinically improved again. So, in conclusion, the anterior cingulate consists of 4 different parts with different networks and different function. Subgeneral anterior cingulate, from an almost phrenological point of view, with the network that's associated with it, encodes value. The pregeneral inhibition, the rostral uncertainty or salience processing, and the dorsal urge for action and sympathetic control. So the anterior cingulate, a rostral to dorsal part, has a sensory, cognitive, emotional, and autonomic function, integration function, because they all overlap, and is involved in all axis 1 psychiatric diseases. It has an inverted U-curve profile and is a target for cingulotomy, and is a potentially good target for neurostimulation as well, as we've shown in tinnitus, pain, addiction, and OCD. And it could be a target for depression, anxiety, and schizophrenia as well, at least from a theoretical point of view. And with this, I will stop and thank you for your attention.